Hello everyone, my name is Paul Young. It's my pleasure to be here talking to you today about oxygen therapy post-cardiac arrest. I'm going to start off with the animal data. These are summarised in the systematic review and meta-analysis of animal trials, where we identified 10 controlled trials investigating different fractions of inspired oxygen in animal models of cardiac arrest. These trials all compared inspired oxygen concentrations of 100% with lower amounts of oxygen for a period of 60 minutes following resuscitation. And despite some differences in the animals studied and the cardiac arrest models that we used, there were some consistent findings across the study. So across those studies, animals that were allocated to 100% oxygen as opposed to lower concentrations of oxygen had damage, dysfunction, and deficits. Neurological damage observed on histological examination of brain tissue, with areas of brain involved including the basal ganglia, the thalamus, and the hippocampus, and cerebral metabolic dysfunction manifest as impaired hippocampal oxidative energy metabolism and decreased brain pyruvate dehydrogenase levels, and neurological deficit scores were worse based on established species-specific scoring systems. So, although these animal data do support the biological plausibility that oxygen therapy might be important for patients after cardiac arrest, there are a number of problems with translating these data. So animals had very short periods of CPR, much shorter than would typically occur for a human. Study treatment only lasted for an hour, and beyond this time there was absolutely no basic supportive care whatsoever, and no efforts to control temperature, or in fact to use any measures to prevent secondary brain injury. As I think you will all be aware, there are a number of retrospective observational studies that have evaluated the association between oxygenation and outcomes in cardiac arrest patients. This was, I think, the first of them, which is an important foundational paper in this area that suggested that hyperoxemia was significantly associated with in-hospital mortality in cardiac arrest patients. Patients with higher arterial oxygen levels had a higher risk of death. The problem is that when you look into this paper in more detail, there are a number of major shortcomings. So two problems are that the way patients were classified as hypoxic, normoxic, or hyperoxic really lacked face validity. In particular, all patients with a PF ratio of less than 300 were classified as hypoxic, irrespective of their PaO2. Also, the study database did not contain key predictors of outcome for cardiac arrest patients, like their initial rhythm of the patients or the duration of cardiac arrest. Perhaps most important of all, it's entirely possible that patients with impaired circulation receive a higher FiO2 because of unreliable pulse oximetry recordings. And if this occurred, then hyperoxemia might simply be a marker of illness severity rather than a modifiable determinant of patient outcomes. Given these issues, it's perhaps unsurprising that various retrospective observational studies have come up with contradictory findings. Indeed, the only consistent finding in the observational studies is that hypoxemia is significantly associated with harm. And while prospective observational studies have been conducted evaluating the association between oxygen levels and patient outcomes, and these studies do include and adjust for important baseline predictors of outcome in cardiac arrest patients, these studies have also resulted in contradictory findings. Study from Scandinavia is a prospective multi-center study where there was no evidence of an independent association between hyperoxia and neurological outcomes 12 months in patients resuscitated from out-of-hospital cardiac arrest. They were unable to verify any harm from hyperoxia exposure. However, in this US study, hyperoxia was reportedly independently associated with poor neurological function at hospital discharge. So unfortunately, animal data and observational studies only take us so far to establish a causal relationship between oxygen therapy and outcomes, and in particular, to establish the oxygen regimen that best balances the risks associated with either hypoxemia or hyperoxemia. We need randomized controlled trials. The largest sample of post-cardiac arrest patients who have been randomized to more oxygen or less oxygen is the MEGARox trial. As you know, the MEGARox trial was published in the New England Journal of Medicine in late 2019. The trial included 166 patients with suspected hypoxic ischemic encephalopathy. And interestingly, when we commenced recruitment into the trial, we did not anticipate that hypoxic ischemic encephalopathy would be a subgroup. However, when we conducted a pre-specified analysis of 100 patients in a Vanguard pilot phase to ensure there was significant separation in oxygen exposure between two groups, and importantly in this Vanguard pilot phase, we didn't look at any of the clinical outcome data. They were not extracted from the database. We found that 21% of patients included in the Vanguard pilot were admitted to the ICU following a cardiac arrest. So knowing that the efficacy and safety of conservative oxygen therapy would be of interest in this group of patients, we added them as a subgroup. With retrospect, I think that the reason we ended up with so many patients who were enrolled after a cardiac arrest was that our eligibility criteria required patients to be enrolled who were mechanically ventilated and anticipated to require invasive mechanical ventilation beyond the calendar day after randomization. And cardiac arrest patients are one group of patients where it's quite easy to predict that that will be required. So, to remind you, this figure outlines the conservative oxygen therapy regimen from MEGARox. We aimed for the just right box that you can see in green. We aimed to minimize the potential for exposure to hyperoxemia by using upper limit alarms to sound when the SpO2 was 97%. And in essence, unless a patient was receiving an FiO2 of 0.21, we treated high SpO2 as an emergency and required the oxygen to be turned down aggressively. Importantly, even when the SpO2 was in this just right box, it was a requirement of the protocol to turn the inspired oxygen down to 0.21 if this was possible. So conservative oxygen therapy in the MEGARox trial was designed to both minimize exposure to high SpO2 and minimize exposure to inspired oxygen concentrations of more than 0.21. For patients allocated to standard care, there was no protocol-defined upper SpO2 limit, and the use of upper limit alarms was not permitted. Patients were discouraged to receive less than 0.3 as a fraction of oxygen whilst invasively mechanically ventilated. And importantly, the plan for dealing with low SpO2 was identical irrespective of which arm the patient was allocated to. So our intervention was aimed to minimize hyperoxemia, minimize pulmonary oxygen toxicity, but not to increase the risk of hypoxemia. So these are the data for the hypoxic ischemic encephalopathy subgroup, and here each silhouette represents one patient. Among this subgroup, 43% assigned to conservative oxygen therapy died compared to 59% assigned to standard oxygen therapy, and that's mortality at day 180, corresponding to a relative risk of 0.73 with 95% confidence intervals that don't quite cross 1. Here's the Kaplan-Meier survival plot showing that the separation in survival occurred relatively early, as I think we would expect from the clinical experience of managing this patient group. That is, most mortality does occur relatively early. These are the Glasgow outcome extended results at 6 months for this group of patients. 55% of patients assigned to conservative oxygen therapy compared with 68% assigned to standard oxygen therapy were classified as having a bad outcome on the extended Glasgow outcome scale. And so the relative risk here was 0.81 with 95% confidence intervals from 0.63 to 1.05. And so while this all looks good and makes for a tidy narrative, 166 patients is not a lot of patients, and there are a number of key questions. So here are 2 key questions. So what was the exposure to oxygen in each group in the cardiac arrest patients? Was there an imbalance in important predictors of outcome for cardiac arrest patients by treatment group by chance? And so these important questions have now been evaluated in a supplementary manuscript published in Intensive Care Medicine. Beginning with the oxygen data, here they are. This is the arterial oxygen data for patients with hypoxic ischemic encephalopathy included in MEGARox. Panel A is the time-weighted mean PaO2. Panel B is the highest daily PaO2. And panel C is the lowest daily PaO2. The blue lines are conservative oxygen therapy and the red lines are standard oxygen therapy. And I think it's fair to say that these are not dramatic between group differences. But it isn't clear what the important measures of oxygen exposure actually are. And despite the lack of statistically significant differences evident on these graphs, there are actually unequivocal differences in exposure in oxygen between groups. So here in the table, which is in the paper, you can see some other ways of looking at the oxygen exposure. And I think when you look at these data, you can see that conservative oxygen therapy certainly increases the proportion of patients who experience at least 1 episode of hypoxemia and decreases the proportion of patients who experience at least 1 episode of hyperoxemia. So the potential for exposure to hyperoxemia is measured by the total proportion of hours when the saturation is 97% or more is substantially lower in the conservative oxygen therapy group. We collected a range of data for the specific analysis in hypoxic ischemic encephalopathy groups, the intensive care medicine paper. They included the details of the arrest, so the first rhythm, the response time, the bystander CPR or not, the time to ROSC, the arrest location, the cause of the arrest, the drugs given and during the arrest. We also collected information on relevant past medical history, focused on cardiac risk factors, and post-arrest care, including targeted temperature management and also the neuroprognostication measures that were used. And overall, these were very well balanced between groups. However, many of the baseline factors that I've just mentioned are very strong predictors of outcome in cardiac arrest patients. And when we conducted analyses adjusting for age, location of the arrest, whether the arrest was shockable, the ischemic time, whether there was a medical cause, and whether the patient had an ST elevation AMI, you can see that the estimates of likely treatment effect are very wide and consistently encompass the possibility of clinically important benefit and harm with conservative oxygen therapy. Of course, MEGARox is not the only randomized controlled trial that's looked at more oxygen versus less oxygen. And I've been working with a number of other investigators on individual patient data and meta-analysis, randomizing patients to more oxygen versus less oxygen after cardiac arrest. This manuscript has been submitted. As shown, we identified 8 randomized controlled trials, and we were able to obtain individual patient level data from 7 of these. We began with an aggregate patient data meta-analysis, and the I squared here indicates that essentially the trials all agree with each other. The risk ratio favours low oxygen, does not quite cross 1, indicating a statistically significant reduction in mortality at last follow-up with conservative oxygen therapy. Now, our individual level patient data meta-analysis offers substantial advantages compared to the aggregate analysis because it allows us to report and adjust for baseline variables that strongly predict outcome in cardiac arrest patients. With respect to mortality at last follow-up, the odds ratio for conservative versus liberal oxygen therapy, you can see there. When incorporating adjustment for age, whether the arrest was witnessed or not, whether there was bystander CPR or not, whether the first rhythm was shockable, the time to sustained ROSC, the adjusted odds ratio remains statistically significant. So for now, we have a summary of the available randomized controlled trial data evidence that suggests conservative oxygen therapy reduces mortality at longest follow-up compared to more liberal oxygen regimens. But the level of certainty here is actually very, very low. The total sample remains small. The treatment effect estimates lack precision. Treatments were administered open label. Decisions to withdraw life-sustaining measures were not protocolized, and only one study reported on the use of neuroprognostic testing, which gives rise to the potential for bias. Because these studies included various different oxygen regimens, and some enrolled patients pre-hospital and stopped treatment at hospital admission, and others started treatment in the ICU and continued it for many days, the data only provide indirect evidence in relation to any specific oxygen regimen. So overall, I think that we are left with evidence that provides very low certainty about the role of conservative oxygen therapy in cardiac arrest patients. This is where we're at for now. I think you can decide for yourself what it all means, but for me, I think we need more data. And the next step for me is MEGARox. This is a trial that will run in New Zealand, Canada, and around the world. This is the number of patients we will enroll in the trial. It's 40,000 patients, very broad eligibility criteria. And we know from ICU rocks that an absolute difference was observed in-hospital mortality of 11.1 percentage points. In the MEGARox trial, hypoxic ischemic encephalopathy is a nested trial, one of a number of parallel nested trials within the overall sample size envelope, and we're anticipating, based on the proportion of patients in ICU rocks that had hypoxic ischemic encephalopathy, that we will enroll 6,880 patients in MEGARox with hypoxic ischemic encephalopathy, giving us greater than 90% power to detect a 4 percentage point difference in absolute, 4 percentage point absolute difference in in-hospital mortality. I really hope that lots of people who are watching this will get involved in MEGARox in Canada, and I hope that it will be transformative in many ways for ICU research and help us to do larger trials that are adequately powered to look at specific subgroup effects. If you're interested in the trial, here's my contact details. Thank you very much for listening.